Dr. Shija Sugunan, Associate Professor and Pediatric Intensivist at SCT Hospital, Government Medical College, Trivandrum. Today, I will be giving a brief overview of pediatric advanced life support. So the question comes, why do we want to treat a tachyarrhythmia? The reason is, when you have a heart which is beating at a very fast rate, the diastolic filling is not happening. So if the diastolic filling is not happening, the cardiac output is going to come down. And when the cardiac output comes down, naturally the patient will go in for a shock and an arrest. So that is why the importance of treating a tachyarrhythmia. Now coming to the question, what are the common tachyarrhythmias that you're going to see in a child? Here the most common one is a supraventricular tachycardia as well as a ventricular tachycardia. So broadly, you divide tachyarrhythmias in children into two, that is narrow complex tachycardia and a wide complex tachycardia. So if it is a narrow complex tachycardia, again you have two reasons, that is sinus tachycardia and supraventricular tachycardia. How do you differentiate between sinus tachycardia and supraventricular tachycardia? So normally we would say that in an infant, if the rate is more than 220, in a child if the rate is more than 180, you take it as a tachyarrhythmia. But you should know that even a sinus tachycardia, that is a child in shock, a child in severe dehydration, may sometimes have a heart rate even more than that. So just by concentrating on the rate alone may not help us differentiate between sinus tachycardia and a supraventricular tachycardia. Then comes the ECG. Yes, there are certain things in ECG that helps us to say that it is SVT. If it is SVT, usually the P wave is either absent or P wave is abnormal. And the QRS, as we already said, it is narrow. But when you are looking at a sinus tachycardia, if the patient is having a heart rate of 200, 220, even in a sinus tachycardia, you are not going to see the P wave. So that alone is not going to tell us whether you're dealing with an arrhythmia or a tachycardia. So it's also important to get the history. So if you have a child who gives you the history that the patient has had loose stools multiple times, has all the features of severe dehydration, and is now presented to you with a heart rate of 200, you are dealing with a hypovolemic shock leading on to a sinus tachycardia. Or if a child has a temperature of 106, hyperpyrexia presenting with tachycardia, that is again a sinus tachycardia. Whereas a patient who comes with non-specific symptoms, some decreased activity, not feeding very well, and having a heart rate having a disproportionately fast heart rate, you should think of tachyarrhythmia. Similarly, another important thing that you have to see is that in case of an arrhythmia, there is no warm up and warm down. That means the rate abnormality happens suddenly. So somebody was having a normal rate and suddenly it shoots up to 180, 200. Whereas in case of sinus tachycardia, there is always a warm up and a warm down. That is, you have a particular rate and then as the temperature increases, the rate progressively increases. And then when it slows down also, it will slow down completely. It doesn't happen, very rapid change does not happen. Similarly, in a sinus tachycardia, there is a beat to beat variability. That means when the child cries, you will have a higher rate. When the child is sleeping, you have a slower rate. Such kind of changes do not happen in an arrhythmia. Arrhythmia is an automatic behavior that is happening in the heart without any feedback mechanisms happening. So this is how you differentiate between a sinus tachycardia and a supraventricular tachycardia. That is, in a supraventricular tachycardia, you will not have any reason to account for the tachycardia. You will have a child whose ECG is either not having P wave or showing an abnormal P wave. You will have a baby who, whether sleeps or cries or does anything, the heart rate remains the same. There is no warm up and warm down. You would definitely, and of course, the rate of higher rate, you would think of an SVT. Now, how do you treat? When a patient presents to you with an SVT, now initially, once you have identified, you can take some ice, crush it, mix it with water, put it in a glove and keep it on the upper half of the face. That is, see to it that it does not obstruct the nose for 10 to 15 seconds. But frankly speaking, I haven't seen an SVT getting reverted with the application of ice on the upper face. So I would say don't waste time for that. While your staff sister is going to get the adenosine, you can use that interim period to apply that. The bigger child, you can make it do the Valsalva maneuver. That may also sometimes abort an SVT. The mainstay of treatment is definitely adenosine. And adenosine is usually, you should know, it is a very fast-acting drug. So for administration, you have to select the vein which is closest to the heart. So usually cubital vein or external jugular vein is selected. But in case you don't get an IV access there, wherever you get the IV access, please do use it. Even through intraosseous adenosine can be given. We insist on using a line as close to the heart as possible so that the drug, before it is metabolized, it reaches the heart. And you always use the 2-syringe technique. Through one syringe, you rapidly push the adenosine, and through the other syringe, you rapidly push the normal saline so that the drug is reaching the heart. And usual dose is 0.1 milligram per kilogram. If it does not revert with the first dose, you will give the next dose as 0.2 mg per kg. If it does not revert, you go to the next dose, that is 0.3 mg per kg, to a maximum of 12 milligram. So, and usually when you take the ECG, you can beautifully see how it gets reverted. Now coming to the broad complex tachycardia, that is ventricular tachycardia with a pulse. So whenever you have a broad complex tachycardia, remember, it can be a ventricular tachycardia, but it can also be a supraventricular tachycardia with aberrancy. So that is why here also in children, the first drug that we give is always adenosine, thinking that it may be an SVT with aberrancy. But if the child does not respond to your adenosine, or if your confirmed case of ventricular tachycardia, the drug of choice would be either going for an amiodarone or going for a lidocaine. And if the child has poor perfusion or the child does not respond to medicines, whether it is SVT or VT with a pulse, you can always give a cardioversion. So cardioversion means the shock is delivered synchronized. Cardioversion is always for a heart, for a tachyarrhythmia with a pulse. So here you are connecting the patient to the defibrillator, and then you are pressing the sync button so that the monitor is able to identify the R wave, and then when you press the deliver shock button, it will deliver the shock synchronized with the R wave so that it does not fall on the T wave. For a child who still has a pulse, if you're going to deliver a shock without synchronization, it may fall on the T wave, and falling on the T wave means that you may precipitate a more serious arrhythmia like a ventricular fibrillation or a ventricular tachycardia. So, it is always synchronized cardioversion for a patient with a tachyarrhythmia with a pulse with poor perfusion. So, I think that finishes the tachyarrhythmias. So, now we move on to the last segment, that is cardiac arrest. So, when you're dealing with cardiac arrest, compared to the adult, in children it is different. In adult, usually we will say that if somebody had gone somewhere and suddenly fell down, went in for an arrest, that is more common in adult. In child, it usually doesn't happen. So that is why the chain of survival is different in a child and adult. The first chain of survival is prevention, because most often the cause of cardiac arrest is an unrecognized or unintervened respiratory failure or cardiac circulatory failure, which has led on to an arrest. So most often in children, you can prevent a cardiac arrest. And another important thing is, whenever you find a child in cardiac arrest, you are always in a hurry to start the CPR. The most commonest cause of arrest in children are in fact respiratory in origin. So we have importance to giving the AMBO in a proper way is important. And usually connecting the monitor, looking for a pulse is slightly secondary. So often out of hospital care, you always say for call for help and start the CPR. Start the CPR. After 2 minutes of CPR only, if you are not able to revive the child, are you going to leave the child and call for the emergency team to come with the defibrillator? So that is the main difference between a child and an adult cardiac arrest. Now coming to, you have a child who is brought unresponsive. How do you proceed? The first is you flick the, if it is an infant, you are going to flick the sole of the leg to see if the baby is responsive or not. Along with that, you will see if the patient is breathing. If the patient is not breathing, immediately palpate for the pulse. Where do you look for the pulse? If it is an infant, you are going to look at the brachial pulse, that is just above the cubital fossa, midway between the two. And if it is a child, or you can also use the femoral pulses. If it in a bigger child, you can also use carotid. In infants, we don't prefer carotid because it is very difficult to palpate, because infants have a short neck. So, and you should take minimum 10 seconds to declare that whether you have got a pulse or not. So now you have identified a baby without breathing, without pulse. So immediately start your CPR. And starting the CPR is just like in the adult, that is, you were going to start with cardiac compression. But here the problem is, which is the site of cardiac compression? In adult, you give between the two nipples. In case of a newborn, it is usually, or a young infant, it will be just below the internipple line. For a bigger child, it is also between the two nipples in the central chest, but above the Xiphi sternum. So that is important. You should never give a cardiac compression on the Xiphi sternum because it may cause breakage. And when you're giving the compression, what is a good compression? A good compression is you have to compress at a rate of minimum 100 to 120 per minute. You have to ensure that interruptions in cardiac compression is less than 10 seconds. You have to ensure that there is a complete recoil when you're doing compressions. Only then, if you allow recoil, only then the diastolic filling is going to happen. So these many things you have to ensure when you're giving a compression. So now you also, children come in various ways. So how do you decide what is the depth of compression for a child? So roughly telling, it is 1/3 the anteroposterior diameter, which basically means that 4 centimeter in an infant and 5 centimeter in a child. For a young infant, in fact, you prefer the two-thumb technique where you encircle the baby in your hands and then give the cardiac compression. That would give you a better cardiac compression. A smaller child, you can use a single hand, and for a bigger child, you can use both the hands together, just like you do it in an adult. So remember that when you're giving cardiac compressions, why we say that the interruption has to be limited to less than 10 seconds is during the initial cardiac compression, the diastolic flow is limited. The major organs are not getting perfused. When you continue to giving cardiac compression only, the flow to the various organs are established. But the moment you stop the cardiac compression, it again comes back to zero and again you have to restart. So that is the reason that you have to interrupt compression as less as possible. So what is the ratio at which you compress? Whether it is a child or an adult, the ratio is 30:2. That is 30 compression and 2 breath if you are a single rescuer. If you are 2 rescuers are there and it is a child, you go for 15:2. So 15, how do you know it is a child or an adult? The child is, an adult would be someone who has features of pubertal changes. That is, if the child is showing axillary hair or child is showing breast enlargement, then you can use the same adult ratio. Otherwise, for 2 rescuer, it is 15:2, and for a single rescuer, it is 30:2. Now, what about delivering of the breath? So, most important thing in delivering of the breath is to use the appropriate size mask. So, your mask should cover the bridge of the nose to the valvula of the chin. Always try to get the correct size of the mask. In case you don't have the correct size of the mask, I would say opt for a smaller size rather than a bigger size, because leak will be more in the bigger size. And also remember that infants have a large occiput. So if you are going to ambu without keeping a shoulder roll, the air may not reach the lungs. So in order to bring the larynx and the trachea in alignment, you have to keep a shoulder roll in a young infant as well as just like in a newborn. In an older child, you can manage it just like you manage adults. So we already said the rescue. So now you have started your cardiac compression. You have 2 rescuers or 1 rescuer. You are following the rate. You are ensuring the depth. And when do you give adrenaline? Give the first dose of adrenaline as early as possible. And the moment you have your monitor available, connect the monitor and look for the rhythm. Remember, there are only 2 rhythms that are shockable. That is ventricular tachycardia without a pulse and ventricular fibrillation without a pulse. A straight line, which means an asystole, does not require a defibrillation. And similarly, if you have some activity there, that is you call as pulseless electrical activity, also there is no role for defibrillation. What are you doing when you are defibrillating? What are you doing defibrillating? You are giving a shock which is at a higher joules. That is, earlier for synchronized cardioversion, you were giving only 0.5 to 1 joule per kg. Here you are giving 2 joules per kg. So you are in fact stunning the myocardium. You are stopping the heart and anticipating that the heart will beat with a normal rhythm. So only 2 rhythms that you go for shock, that is pulseless ventricular tachycardia and ventricular fibrillation, that is for defibrillation. Now, and once you have given a shock, please don't look at the monitor whether the rhythm has reverted. Just give the shock and continue with your CPR. After you have completed 2 minutes of CPR, go back and see what has happened to the rhythm, because soon after the rhythm is reverted, the heart may not be pumping with enough force to get a good cardiac output. So that is why even after soon after a defibrillation also, you are recommended to continue with the CPR. Now you are continuing CPR, but the child is not getting reverted. What do you do? Every time you find that after a good CPR, the return of circulation is not happening, immediately look at the reversible causes, that is the H's and T's. That is, look if the patient, you have connected the oxygen, maybe the patient is hypoxic, maybe your ventilation is not right. Maybe the child was severely acidotic even before, think whether soda bicarb is needed or not. And there may be hypoglycemia which needs to be corrected, otherwise the child is not going to get reverted. See if there is a setting for hypo or hyperkalemia. Child coming with diarrhea and cardiac arrest, probably hypokalemic arrest. An empirical potassium may be given as an infusion. If the patient has a history of decreased urine output, probably you are dealing with a hyperkalemic arrest where a calcium gluconate may be of the role, or a glucose insulin infusion may be of role. Small babies, if you keep hypothermic, you will not be able to revive. See that the warmer is on and you are also taking care of the temperature. Similarly, look for air entry on either side. Are you dealing with a tension pneumothorax? Are you dealing with a cardiac tamponade? Are you dealing with toxins which may revert with an antidote, or are you dealing with a thrombosis? So the 5 H's and 5 T's should also be thought in mind every time a child is not getting revived by a cardiac arrest. And what are the drugs that you use in cardiac arrest? If you're going to use adrenaline, it is dose the same 0.01 mg per kg, but you always take it as 1 in 10,000. So then in ml, it would be 0.1 ml per kg. You can repeat every 3 to 5 minutes. If it is amiodarone, you give 5 mg per kg as bolus. It can be repeated 3 times to a total dose of 15 mg per kg. That is only in case of refractory ventricular fibrillation and pulseless VT, which is not responding to your defibrillation. So now if you are in a public place and you find that the child has suddenly arrested, I already said a witnessed cardiac arrest is often due to arrhythmia. There is of course definite role for looking for the rhythm. A hospital arrest, a child who is already sick arresting is usually not due to arrhythmia, but witnessed, otherwise normal child suddenly falling is definitely often due to an arrhythmia. So in that case, looking for the rhythm is important. So if you are in a public space and you have an AED available, use the AED just like you do it in adults. If there is a dose attenuator available, pediatric, you can use that. If you don't have a dose attenuator, same adult AED can be used. Just see that the AED stickers that you're keeping, they don't touch each other. If it is a small baby and this is quite big, you can keep it antero-posteriorly also. Now coming to the last segment, that is, how do you approach a child who presents to you with bradycardia? So here you can see a child coming to your ER with a heart rate of 40 per minute. What are you going to do? So the first thing that decides what you're going to do is whether the child is showing a circulatory compromise or not. What do you mean by cardiopulmonary compromise? Is the child showing features of poor perfusion? Is the child having hypotension? Is the child having altered sensorium? If any of that is present, that means this child is in a cardiopulmonary compromise and immediate intervention in the form of CPR should be started. Whereas if you're finding a bradycardia in a child who's sitting there and talking to you, it may be a case of a congenital heart block. It may be something else which you can take an ECG, decide what to do, and you have time to act. Whereas cardiopulmonary compromise, you don't have time to act. Remember, in pediatrics, whenever you have a child with bradycardia with a cardiopulmonary compromise, we don't start with cardiac compression. Instead, we usually start with AMBU because the commonest cause of bradycardia in a compromised child is respiratory in origin. And when you're giving an AMBU here, you have to give one breath every 2 to 3 seconds, that is 20 to 30 per minute. And even after adequate ventilation and oxygenation, if the heart rate does not pick up above 60 per minute, then you start your cardiac compressions also. And if the bradycardia is persisting, definitely drugs may be given. The drugs given is usually, if you are thinking that it is cardiac in origin, the drug recommended would be going for an atropine 0.02 mg per kg with a minimum dose of 0.1 milligram and a maximum dose of 0.5 milligram. If you think the cause of bradycardia is non-cardiac arrest, that is a preeminent routine cardiac arrest, the child is having bradycardia, you can use adrenaline itself, that is 0.01 mg per kg or 0.1 ml per kg of 1 in 10,000 solution. So that is in nutshell, we can talk about pediatric advanced life support. Of course, you also have post cardiac arrest stabilization also, but I think I would stop here. So what are the main take-home messages? Main take-home messages is always do a systematic examination, identify an abnormality and intervene. Do the initial impression to find if the child is having a life-threatening disease, yes, no. Do the primary assessment to identify the physiological status of the child, to identify if the patient is in respiratory failure, a circulatory failure, or you have a brainstem or cortical dysfunction. That is the aim of primary assessment. If you find any of these, immediately intervene. Then proceed to the secondary assessment, where you have the sample history, a head-to-foot examination, a secondary assessment, appropriate investigation, and reach a diagnosis. If you really follow this chain of examination, identification, and intervention, you will not miss important life-threatening problems in a child. It's also important to distinguish between distress, failure, compensated, and hypotensive shock, because once a child is in respiratory failure, child is in hypotensive shock, cardiac arrest may be minutes away. And once you detect a cardiac arrest, if you do an approach, it can always be prevented. Remember, mostly it can be prevented in a child. And once it is detected, appropriate CPR and appropriate post-resuscitation care would ensure a good neurologically intact survival. Thank you.